congratulations in advance for this fantastic, successful meeting. I think it's the most successful meeting we ever had in numbers, at least, and in sessions. I did hear from you, we had more than 900 sessions, both in internet and face-to-face sessions. It's amazing success. I'm really sad that I couldn't make it physically to be with you. But anyway, it's a pleasure for me to chair this session. It's going to be practical session, hands-on, real cases, and have opinion, a quick opinion from the experts that they agreed to participate in this session. And I'm grateful to Katrien Devreese. She is a consultant hematologist and coagulation from Belgium. Professor Guillherme De Jesus, he is consultant obstetrician, and Guillermo with Irastorza, consultant physician from Spain. So we have a variety of specialty here with us, and their opinion could be different because there is very little evidence-based medicine. Let's face it, in the management of antiphospholipid syndrome. Perhaps we have some data on pregnancy, very little about thrombosis. So it will be interesting to debate and have short answers, please, from the three experts, but would love to have participation from the public as well. This is for my conflict of interest declaration. I work with GSK since 2020, but I secured part of my time, about 5% of my time, for academic activities. So that's always a part of my arrangement with GSK, that I'll keep my activities intact. So what's curbside consults? Okay, this concept is something that you face, me, everybody, in daily basis. When you arrive to the hospital in the morning, some colleague, he didn't see you for a while, he will tell you, wow, nice to see you, because my sister, she was recently diagnosed with antiphospholipid syndrome. I would like to have your opinion. And in the corridor, he asked you questions about his sister, and you answer, but you didn't see any blood test or anything. Just you took his words and you reply according what he asked you, and that's it. End of the story. So you give your opinion, not based on anything other than expert opinion in this case. And here, what the idea here, to give your opinion, short answers to my questions, and we debate whether the answer is based on evidence or the answer is just based in experience. So let's face the first case, okay? A real case, okay? A 24-year-old female patient who owns a horse farm, has an intrauterine fetal loss at 6 months and developed postpartum 1 week after the delivery, left internal jugular vein and ovarian vein thrombosis. She has been diagnosed as having APS with triple positive, cardiolipin, lipase anticoagulant, and beta-2. And she was treated with warfarin for a period of 2 years, and she is now totally asymptomatic. She came back to the clinic and say, all right, I am feeling very well, as my hobby in life is horse riding, and I would like to ride a horse, start again. I am taking warfarin. So let me ask the hematologist first. Katrien, will you consider this a candidate to stop, not only give aspirin, whether you give aspirin, we can discuss this later, to stop anticoagulation altogether, because this could be considered, according to the international guidelines by thrombosis and hemostasis, this is provoked thrombosis. There is no need to prolong anticoagulation. What's your opinion on this? Katrien?
Yes, okay. Thank you, Munther, and thank you for inviting me to be part of this panel. If I see the history of this patient, it seems a rather hard history with 2 thromboses. So for me, this is a serious case of a combination, in fact, of pregnancy complications and thrombosis with triple positivity. I do not know whether this was measured again before.
Confirm.
And she's still triple positive.
Yes.
also after 2 years of the treatment, she remains
Yeah.
triple positive.
The treatment is warfarin only, so you don't expect the antibodies to go away with warfarin.
So
What we do, she is asking you a practical question. She is your patient, and she tell you, I would like to ride a horse. Will allow her to ride a horse with warfarin?
I think horseback riding is anyway a risk when you fall, and, and certainly for bleeding. So, and in her situation, I think you have a high chance that she has recurrent thrombosis, I think, when she is still triple positive.
Okay.
So anticoagulation.
So what
yeah.
What you will stop it at this stage? She has 2 years of anticoagulation.
No, I should not stop the anticoagulation. No.
Okay, Guillermo Ruiz.
Well, I would try to convince her to change sports. I think.
Yeah, Graham Hughes, when I presented this case, he said, shoot the horse.
Yes, not that much, but I think it's very risky to withdraw warfarin, and also it's risky to ride a horse being on anticoagulation.
Well, I'm not going to tell you, when I presented this case in London, a senior hematologist suggested she will stop even aspirin and warfarin because this is, in her mind, is provoked thrombosis. Do you agree with that?
Yeah, I mean, it is provoked thrombosis, but she has also a late miscarriage, and she's triple positive. So it's quite likely that this lady has a real antiphospholipid syndrome. So I think we face a great risk of recurrence if we stop warfarin.
Okay, so in which situation we consider provoked thrombosis and non-provoked thrombosis that hematologists talk about in their guidelines? So if this is not provoked, so what do you consider provoked?
No, this is provoked. This is provoked.
But you don't want to stop warfarin.
Because she has a context of antiphospholipid syndrome. She also had a fetal death, and she is strongly positive, triple positive with with repeated tests. So I think the risk in this case is high. Even in the case she had a clearly provoked thrombosis with these antibody profiles, I would think twice or thrice before stopping warfarin.
Katrien, you agree with that? You will keep her with warfarin?
I should keep her on warfarin, yes. Yeah.
Long term, forever then?
Yeah, long term, yes. Because
De Jesus,
I think she will have recurrent thrombosis in that situation to prevent it.
Okay. Guillermo De Jesus, do you want to contribute here, or shall I move on?
I would say she has a risk factor, but the two thromboses are very separate. It's not like, I'd say like a small thrombosis or something. It's on ovarian vein and jugular. They are very far away from each other. So with a high risk profile, I would see that patient like very high risk for a new event. At least that's what I think.
Okay. I agree with you, but I was challenging, as I told you, senior hematologist in London, and she was adamant about that. And but I agree with all of you. I won't stop it. I will persuade her to not horse ride, and I persuade her to carry on taking warfarin myself. And this is based in sort of evidence. It's a retrospective study we published many years back, as you know, became standard of care, because aspirin alone is not going to protect her. And we showed that published that in New England Journal of Medicine, and in our hands, at least for venous and arterial thrombosis, warfarin long-term is the best choice. If you give aspirin alone, it's not going to protect her, and she's 24 years old, and I think she will have recurrent thrombosis in herself. Now, do we have more data about cessation of anticoagulation in such cases? Well, Piet have data. Piet has a huge center in France, as you know, like our center in St. Thomas's Hospital. And when they assessed in those patients who stopped anticoagulation, like in this case, for example, if we decide to stop her anticoagulation, the chance of have recurrent thrombosis is quite high. And even he stated in his publication even if the antibody disappear, that doesn't mean you stop anticoagulation. And this is based obviously in retrospective studies. We don't have evidence-based medicine here in prospective fashion, but there is some data to suggest, hey, this kind of patient are too risky to stop anticoagulation. So I agree with all of you, okay? If anybody in the audience would like to participate, you're welcome to interrupt. And Paula is there in the audience, can help me on that. Especially in this case, the triple positive, as all of you suggested, this is now it's accepted by everybody working in the field. This is the profile with high risk. Now we agreed to the patient should be with warfarin.
Dr.
Which
Munther?
INR? Yes.
Dr. Munther, Mercedes Garcia wants to ask a question here.
Yes, please, go ahead. Go ahead. This is the idea, please. Go ahead.
Hi, Munther. No, not a question.
Yeah.
I mean, I think it's a matter of quality of life. It's a young woman who, if she's not horse riding, she goes to dance, she does other things that put her in sports, thank you, put her under risk. And maybe she suspend the medication by herself.
Yeah, this happens all the time. But happens all the time in medicine. You cannot force anybody to take anything in life, okay? You counsel these patients and you give your opinion. I agree with you. She might choose, hey, hell with your advice. You didn't give me enough evidence that I should remain in warfarin. Whether you like it, I am going to take aspirin and stop my warfarin. She can do that perfectly. She can do that, and she's entitled to do that. But my question is whether you actively will allow her to do that. It's her choice at the end of the day. Mercedes, is her choice, obviously her choice, quality of life. Anyway, we decided to anticoagulate this patient. What's the target INR? And we agree that target INR is controversial between hematologist and rheumatologist and internist, worked in the field, but we compromise. I think for me, for venous thrombosis, I am happy for INR to be kept in between 2 to 3. But let's suppose this patient have arterial thrombosis. Let's suppose, just for the argument's sake, will you accept INR 2 to 3 and add aspirin to this? I know Guillermo have some data on this, and this is why I would like to target the question to Guillermo.
Well, now it's our first option. You put on the slide with my name there, along with you. And we have defended the option of high-intensity oral anticoagulation for arterial. But by now, in our unit, we put patients on 2 to 3 plus aspirin when they have arterial thrombosis. We think it's
with good results. I know you have good results on that as well.
Yeah. And I think there are data, published data, and it's easier to have a 2 to 3 than a 3 to 4 anticoagulation. And I think the platelet plays an important role, and the aspirin covers very well. I don't think there is a major risk of bleeding, and now it's our first option.
What about you, Katrien? Is she still user of 3 to 4, or you are in favor 2 to 3?
2 to 3. Yeah.
In arterial?
Sorry?
In arterial thrombosis, in stroke, patient with stroke.
Yeah, that's of course a point of discussion, but I think 2 to 3 is, yeah. I should take 2 to 3, not higher, not a higher target.
Even in patient with stroke?
With stroke, you should add antiplatelet, I think.
Well, like Guillermo said, okay.
Dual therapy then, yeah.
Okay, let me move on, okay? Would you consider DUACs in this patient? I know you have a big debate yesterday or this morning about this, that whether DUACs could be considered here. And you as hematologist, this patient is young, saying, okay, you convince me I need to carry on taking anticoagulation, but I did hear that it's better to take tablet rather than controlling my INR all the time coming to the hospital. Will you allow that specific patient that I presented to take DUAC? Katrien.
No, I should not give her DUAC because she is triple positive with her history. Yeah. So no, I wouldn't take the risk to give her DUAC. No.
Did Hannah Cohen defended that in some patient we could use or not?
I didn't understand.
Hannah Cohen had debate. I didn't.
Yeah,
I
was
couldn't
not,
attend the debate. In the debate, did you conclude that occasionally in some patient, if they insist, you can use it? What's her stand today? Hannah Cohen, which she did the study with me. Let me tell you the study. RAP study was done in our department as well. Pengo study included venous and arterial thrombosis, unfortunately. Cohen, when we did the study together, was only venous thrombosis, and 25% of patients were triple positive, and nothing happened. They were okay. I know the current recommendation is triple positive, don't use DOACs, but do you agree with that? I know the recommendation, but do you agree as hematologist and this patient come to you specifically saying, I would like to take it? You will try to persuade her 100%, or you'll just say, well, there's no evidence and maybe the small evidence is too risky in your case, but she's only venous thrombosis.
Yes, but you don't know, second time it can be an arterial thrombosis.
That's true.
Yeah.
As I agree. But so you definitely will not allow her. Guillermo, will if this patient insists to take it, rivaroxaban, for example, will you allow her to take it?
I think with the current data, it's difficult to allow her to do this. It is true again. I don't know. We have talked about this before. I don't know why nobody has tried to combine the DOACs with aspirin, precisely to avoid recurrent or first arterial thrombosis. But for time being, I think there are no data, and I think the data says that the risk of a triple positive patient on DOACs, even with the first venous thrombosis, of having an arterial thrombosis afterwards is high. So I think that nowadays it's difficult to change to a DOAC in this patient.
What it makes it difficult is this, because once the trial of Pengo was published, the European community with EMA, they issued a statement about the use of DOAC in patients with antiphospholipid syndrome, and they decided they shouldn't be used. And that was a dramatic decision. And if you look at the second recommendation, those patients with DOACs should be asked to come to your clinic and counsel them and tell them, look, the current recommendation is not to use DOACs, and ideally you should stop it and change back to warfarin. Have you done this in your patients? Have you followed the recommendation and the guidelines in Europe? Have you done it, Guillermo? Did you ask your patient to come back to clinic and change to anticoagulation?
No, the thing is, we have very few patients with DOACs because we don't usually see the venous thrombosis in regular population. And in Spain, this is much regulated. I mean, the use of DOACs is very much restricted. So you have to have a good reason. You have to have a contraindication for warfarin to use the DOACs in the long term. So
what about you, Katrien?
I have one patient who was already on rivaroxaban plus aspirin because it was very difficult to control her disease, and she had previous arterial and venous, and I didn't change. She's still on that, and she's doing fine.
She's doing fine. We have many patients at St. Thomas's Hospital when this came out, but they remained on it, but after counseling. What about you, Katrien? Did you have patients who were taking DOACs, and when this regulation from EMA came out, you have to call these patients to your clinic and tell them to stop it?
In Europe, we adhere still to the EMA recommendation, certainly in triple positives, not to give DOAC.
Yeah, but you see, what the recommendation is saying, if you have some patients with taking DOAC, you have to call them back to the clinic and tell them to stop it actively. You tell your patient to stop it and change back to warfarin. Have you done that in your patients?
I have, to be honest, I have no experience with that. When they are on DOAC, and once you know they are triple positive, to change back to warfarin. I have no experience.
This is the recommendation from IMA. This is the recommendation from IMA. This is what you should do. But anyway, let's move on. Now come back to the patient and we'll come to De Jesus. She said, okay, I have one dramatic pregnancy, stillbirth. I lost a baby, followed by dramatic thrombosis, but I'm doing very well. I am 24 years, 25 now, 26 now. I want a baby. What's your recommendation in this specific case? Will be aspirin and heparin, is that correct?
Yes, in full dose heparin, twice a day.
Okay, I agree with that. I put
the
it
aspirin,
in.
please. Keep the aspirin.
Okay, that's fine. That's fine. Now, I can tell you, and this is real, she had another pregnancy, and she had miscarriage, unfortunately, with heparin and aspirin. So what's next?
How old is she?
26.
All right. I would try
27.
again. Sorry, 27.
You will try again.
27.
Yeah, 26, 27 when she lost the first trimester miscarriage, yes.
First trimester, early miscarriage.
Yeah.
Okay. I think we will discuss with her, but we could try again, same regime.
She will not accept that, Guillermo. You know that. Patient wants something else.
Maybe given the aspirin preconceptionally. Aspirin
Okay,
plus
that's good
warfarin,
point.
and then changing warfarin for heparin when she's pregnant. I think it's not a major
Well,
issue.
let's see what the obstetrician will do. What you will do, De Jesus?
Sorry, what was the question? I didn't hear it. So,
She had one miscarriage. She had one stillbirth, and then 2 years later, she fell pregnant again, but she had one miscarriage. The first pregnancy was untreated. She didn't know she had antiphospholipid syndrome. The second pregnancy, she received aspirin and heparin, and she failed. And now she would like to come back to you saying what you're going to do next. Guillermo said, try again with aspirin and heparin alone.
okay.
Will you give something else other than that?
Well, first, I would try to have more information about the miscarriage. If she has a very early miscarriage, it could be a genetic cause. So I would try to offer to do a genetic test on the miscarriage. But if you don't have the information, like the patient just come back with that, I would consider all of those. Maybe hydroxychloroquine could have some point, but we are looking that patients with recurrent abortion, they have APS has more impact on miscarriage that we used to think. So I would say that I'm not sure if the miscarriage is actually caused by APS, and if they have some kind of signs of genetic cause, like an embryonic pregnancy, it's very associated with genetic problems. I would like keep the same treatment, aspirin and heparin, full dose, and say that was like a normal obstetric cause, not APS, and keep it. But if there's something that looks like APS, like severe preeclampsia again, or something like that, or late fetal death, then we could try something, maybe hydroxychloroquine. But the other ones I wouldn't.
You are not taking into account her previous history.
I'm sorry, I couldn't.
You are not taking into account she had stillbirth. You are focusing only in the last pregnancy, which was early. But this lady had a stillbirth. 2 years ago, she had 6 months baby lost. 6 months. She was pregnant 6 or 7 months. Okay. So that should be taken into account here. And in myself, I'll add something. I compromise. I don't know, obviously, the genetic could be genetic, nothing to do with antiphospholipid syndrome. I agree 100%. But in this situation, you have to take the history into account, in my view at least, and consider this lady had already 2 losses. One of them late, which is typical of antiphospholipid syndrome. She's triple positive. We gave her the chance to fall pregnant with heparin and aspirin, and she failed. Maybe through genetic reason, nothing to do with antiphospholipid syndrome. But myself, I will give benefit of the doubt, and next pregnancy, I'll add something else. Whether steroids or hydroxychloroquine, IVIG, I don't know, but most likely hydroxychloroquine. Guillermo, you want to give hydroxychloroquine to this case?
I would try preconceptional aspirin. I said, I think first time the fetal death was untreated. So this
untreated.
This
is how discovered. It's important. It's relevant. Guillermo, it's relevant.
No, of course, it's relevant. But she's now treated with aspirin and heparin, and she had a nerve miscarriage. So it depends. But this is a 7-8 weeks miscarriage. I wouldn't automatically attribute to APS, and I think you have the option of giving her aspirin preconceptionally, even when she is on warfarin, because there's no problem of combining 2 to 3 with aspirin, and then change the warfarin to heparin when she's pregnant. She's 27. We have time enough for the next.
It's easy to say that.
I understand. We have to discuss. I understand that. We have to discuss this with the patient, but I think this is an option.
Okay, anybody in the audience, Paula, would like to intervene here? Paula?
Yes?
Anyone in the audience want to say something?
No? Move on?
Yes.
Yes.
Okay. This is case 2. Let's move on, okay? This is a 32-year-old female, presents only with severe cognitive dysfunction, decreased visual attention, difficulty in word retrieval, and concentration. Demonstrated by neuropsychiatric testing, so it's confirmed by psychiatrists and neuropsychiatrists. She has no history of SLE, no history of cerebral vascular events, or any other thrombotic events. MRI of the brain is normal, okay? Lupus anticoagulant test is positive, and IgG ACL is positive, high positive, confirmed in several occasions. How will you manage this patient in the long term? Let's start with the hematologist. Katrien.
This is again a not easy case. So lupus anticoagulant is positive, IgG is low positive to me, 67, this is low positive. At least, can you say with which method is anticoagulopin measured? Because that makes a difference to consider it as a single LA positive or a double positive.
No, several times. It's confirmed. At that time, this patient, we didn't have beta-2 glycoprotein 1, but it wasn't tested. But IgG ACL confirmed several occasions, 67, 70, 75, something like that. And lupus anticoagulant consistently positive, several occasions. So no doubt about the testing. I promise you, no doubt about the testing. Real case. What you suggest we should start with? Treatment, just what you do. Is interfering with her life, a serious cognitive decline, okay, serious.
So what, the question is, in fact, will you her anticoagulate or not?
No, whatever. What do you do? What you will do? This come to your clinic, what you'll do?
What do you do with the patient? How do you manage the patient?
Yeah, so the question is to anticoagulate or not, or just to follow up her. Yeah, that's it.
Okay, so you will anticoagulate her?
Sorry?
You will anticoagulate her at this stage?
No, I'm not convinced to anticoagulate that kind of patient, no.
Okay, Guillermo?
No, I think it's very difficult to anticoagulate a patient with a normal MRI. I think aspirin is an option because she's got a lupus anticoagulant, so there's nothing against that. But I think she deserves a more deep neurological study because it's not normal that a 32-year-old woman with a normal MRI, despite the positivity of antiphospholipid antibodies, has such a big cognitive dysfunction. So I'm not convinced that this is due to APS. I think aspirin could be given because she's LA positive, but she needs more study for this.
Okay, that's the real case, but I would like to change the case slightly myself.
Yeah.
And I tell you the MRI showed hyperintensity lesions, okay? Different, and now a hypothetical case. Now I am diverting from the case. So this will change your advice? You will anticoagulate this patient now?
Yeah, I think so.
The same patient, but with this scan. Scan in front of you, is hyperintensity lesions, which is quite suggestive of antiphospholipid syndrome anyway. Will you anticoagulate this patient now?
Yes.
What about the hematologist? Katrien, will you anticoagulate this patient now?
Yes, yes.
Okay. Anybody in the audience would like to intervene? This is a real cases. I promise you, this is not invented cases.
Dr. Munther?
Anybody in the audience would like to? Yes.
Alejandro Babini would like to ask a question.
Okay.
Hello, Munther. Maybe
Hi.
in your first scenario, I can imagine Dr. Hughes giving this girl a trial with low dose sub-Q heparin and monitor
Correct.
her neurologic symptoms. In the second
Correct.
one, maybe we can think about a little more because you
Exactly. Most of us in this situation will anticoagulate, but
Yes.
in this situation, Graham Hughes, I learned this working with him anyway, a trial with low molecular weight heparin for 3-4 weeks. And I tell you, when the response is good, the patient come, as soon as she opens the door, you know there is bad news or good news. Her smile will be a huge smile if it works. And I saw that working in many occasions. I am not trying to recommend that you anticoagulate this kind of patient all the time, but you know, it's worth having a trial, small
maybe
trial,
not, but
3 weeks.
she's 32 years old, and if there
Yeah.
isn't anything else,
Serious for me, yes.
we could
I agree.
we could try.
Aspirin is easy, but aspirin will not resolve this, and
No.
heparin is much more effective.
No, I don't say aspirin will resolve, but I think that there are many other reasons for cognitive impairment and antiphospholipid syndrome. So I'm not
That's true.
convinced.
Guillermo is true, but again, the neurological manifestations of the antiphospholipid syndrome are not only stroke, stroke. This is a real, not Graham Hughes because dwell on it. I tell you, you worked with us and you know.
Yeah,
we
I
see
know.
this kind of patient. We see this
Yes,
kind of patient. I
but
promise we see this.
yeah, but usually when you have a severe cognitive dysfunction in this kind of patients, you have
You have
small
this scan.
white
You have this
list like
scan.
this. Yes, this is
Yeah,
the
you have
typical
this scan.
MQC.
Yes.
With an absolutely normal MRI, wow, it is very hard to take the decision of anticoagulation.
Guillermo, will
Try
you
it.
consider
Try it. Yeah.
will you consider another treatment beyond the anticoagulation in the second scenario of this patient?
In this one,
In this one,
yeah.
What-
I will give, yes, warfarin 232 plus aspirin.
okay. But Paula saying other things other than anticoagulation. I
In hydroxychloroquine or whatever. Well,
Yeah.
you have nothing to lose, but I think I would keep it in my pocket just in case. So I think you don't need to put everything since the very beginning. So I think you can try the usual approach, and then if things don't, in some months there's no improvement, then you can think of, again to add hydroxychloroquine or statin or both.
Okay. How you manage this patient in pregnancy, De Jesus?
Well, at least low dose aspirin for her, for considering the positivity for APL. That's what we should do. Then I will discuss with the rheumatologist, like how you are seeing this, like the discussion you are having here. So if the patient comes with warfarin, I would keep the anticoagulation.
No. She's not anticoagulated.
She's not
Forget anticoagulation.
Okay, just low dose aspirin. I wouldn't use heparin for her.
Why not? Why not?
Because it doesn't have any strict manifestation. The rheumatologist decided to not to anticoagulate her. So this APL could be just like a small finding that was not related to the main cause, considering the MRI, the normal MRI, right? So
Yes.
I would just do low dose aspirin, but when we have this kind of patient, we still keep looking for severe preeclampsia and growth restriction, just like any patient with APS. So monthly ultrasound and Doppler studies, because they might develop obstetric APS. So we have the low dose aspirin, but we are not like giving her to the midwife to take care of her. We keep it on the high risk pregnancy clinic.
Okay, let me tell you a fact. Let me tell you a fact. You are experienced in the antiphospholipid syndrome and you are obstetrician. But many obstetricians, as soon as they smell lupus anticolon, anti-cadherin antibody, in pregnancy they give heparin anyway. You know that, internationally, you know that.
Yeah,
not based on evidence, but they do it. They do it, you know that.
yes.
I would like to ask Katrien how often she will recommend to take again this antiphospholipid, and which profile will you last to this patient in the next check?
I didn't understand.
How often do you check again
Yeah.
the antibodies?
In fact, strictly you only have to measure it twice. So when it is persistently positive over 3 months, normally you stop. But now more and more the tendency is to remeasure every 6 months, every year. But in fact, we have not really evidence that it is useful, because there are few studies following the patients. There are studies describing fluctuation of antibodies. But today we have not much evidence that we have to keep measuring every 6 months or every year.
Just answering to Munther. Yes, Munther, I agree with you. The obstetricians a lot of them will start heparin. Maybe we try to argue, maybe you, hematologists should try to argue, because she doesn't have the full flag diseases. So, and then we can have, if you test everyone for APL, you know that it's going to have some positive tests that are not actually related to disease. But obstetricians that are not used to deal with APS, they think there's the baby can die at any moment, and it's not what we see when the patient has appropriate treatment. Usually when we have bad results, it's like a very severe preeclampsia, very early preeclampsia or growth restriction, but there's not like the baby's fine with appropriate growth, and then all of a sudden he's dead. It's not what we see when the patient has appropriate treatment. So that's, like I said, we need to keep looking like she's a high-risk pregnancy patient, but we don't need heparin. It's just going to have a mess for ourselves, because we are going to have delivery with heparin. If the patient is a high risk, we accept the risk of bleeding during the delivery. That's fine. Okay. But this case, we couldn't prove it's APS. That's my point.
No, it's not proven APS yet. Okay, definitely not with criteria APS. Okay. Okay. Now she will tell you, I am worried about COVID and I would like to take the vaccine. You will have any concern here? Guillermo.
Well, I think Vittorio presented data on a study, an Italian survey, and they didn't see problems, even with AstraZeneca, although the number of patients with AstraZeneca was very low.
Small. Yeah, small.
In our practice, when the thrombosis with thrombocytopenia with AstraZeneca started to show up, we convinced the authorities to not to give patients with APS this vaccine. Although the mechanisms are different, I think it would be more sensible not to give them this kind of vaccine. But it seems that the risk of thrombotic events is low, so there is no problem.
Katrien?
Vaccinating her.
Yes,
Katrien, you have.
I agree. I think there is no problem to give her the vaccine.
Do you have in this specific case, will you recommend, for example, Moderna or Pfizer over the traditional vaccine?
If you have the choice, yes, it's maybe better not to give AstraZeneca. Yeah. However, it's not proven, of course, but if you have the choice.
If you have the choice, you prefer to give the, okay, fair enough. Anybody would like to intervene here before I move to the third case? No, Paula? Move. Okay. Let's take another case. This is a much more complicated hematological case. A 24-year-old female patient with primary APS, left thigh deep vein thrombosis in the absence of other hypercoagulable states. High positive anti-cadherin antibodies, tested on several occasions over several months. On warfarin target INR 2 to 3 without recurrence for 1 year. In 2019, another episode of deep vein thrombosis, again in the left thigh again, treated with warfarin target INR 3 to 4 now, because it's second clot. Now you receive urgent call from her GP in November 2020 asking for help since his patient suffered another deep vein thrombosis, this time in the other thigh, in the right thigh, with pulmonary embolism. So we have now, let's call it a refractory case to warfarin. Let's put it in this way. What is your advice, Guillermo? And I know we did studies together, you and me, in St. Thomas's Hospital, showing that it's your dream to have 2 to 3 or 3 to 4, but to achieve that dream doesn't happen all the time. So could you comment on that?
Well, I think there are two things. One is this is unusual, and I think being in venous thrombosis, even though the patient is young, I think you are absolutely obliged to look for something else. And when I say something else, I see a cancer. I think we have had a patient with this profile, and she eventually had a myeloma, and it was very difficult to demonstrate that. So I think you have to look for something else going on. This said, I think maybe the first action would be adding maybe hydroxychloroquine if everything is normal, or even while the study goes on. But I think it's a real challenge. So first, trying to check whether the thrombosis happened with an INR in range. Second, maybe adding hydroxychloroquine, and third, looking in parallel, looking for any other disease like cancer, explaining this resistance to anticoagulation.
Katrien?
Yes, I agree. You should exclude an underlying disorder, I think, in such a young patient with different thrombosis, recurrent thrombosis. And imagine that you, for instance, find a malignancy or something like that, you could then low molecular weight heparins give a try.
Okay, let me trigger another question here. Will you use filter in this case? Filter.
Yes, please.
I'm asking Katrien, the hematologist. Let's start with the hematologist. Katrien, will you use filter here?
I didn't hear what you say, sorry.
Filter to avoid pulmonary embolism.
Yes, that's an option, I think, yes. Certainly.
Have you done it in patients with antiphospholipid syndrome? No.
Sorry?
Guillermo?
The patient I just told you, she was put a filter, and that was a nightmare because the filter got eventually thrombosed and it was impossible to remove. So the filter is something which is for a very short period when you have the risk of a massive thromboembolism, but for medium to long term, I think it's more problems than solutions. I wouldn't use a filter in this case.
Okay. But there is data in the literature, controversial. Some people saying it's safe. Some other people, like our hematologists at St. Thomas's Hospital, say never.
Like somebody like this, I mean, for instance, you have a patient with contraindication for anticoagulation, you can put a filter for a short time. But in this case, which is a lady which has recurrent thrombosis despite anticoagulation, I think the risk of a new thrombosis in the filter is very, very high. And this is not.
Dr. Munther, Dr. Molnar, hematologist from Córdoba, would like to ask a question.
Yes, go ahead, please.
No, it's not a question. I think the filter is not a good option because the filter, the indication is in the patient who bleed. And because the filter gives many complications and thrombosis and post-thrombotic syndrome in young patients.
Yes.
But in this case, I think the best drug with the low molecular weight heparin, the problem is the expensive, is to keep the treatment on the time. But
Yeah.
a patient
I
with
have
multiple recurrences is you update the INR to 3.4. You can add another drug like aspirin, hydroxychloroquine. In this case, I use low molecular weight heparin, I think.
I have done that, and in the publication you have in the middle, therapeutic dose low molecular weight heparin, we have about 30 cases at St. Thomas's Hospital, long term. And it's not ideal, as you said, it's very expensive. It's very, you know, to do it for a long time, the years and years. I have one patient from Israel, she took it for 15 years. It's not ideal, but it's an option, What about, you know, biologic therapy or extreme cases, stem cell transplant? I don't have personal experience, but some other people did that. Any comment here from hematology point of view? Guillermo.
Well, I think rituximab for thrombosis, I think there is nothing proven. And I think it's not an option. And stem cell transplantation, I think, is too much for me. I think you have.
No, there is a few publications, believe it or not, in blood.
Yeah, for sure. Yeah. I think it is too much. Yes, I think. Well, you have several options before going to that.
Okay, let's go to De Jesus. She's crazy enough to tell you, despite all of this, I want to fall pregnant once the acute thrombosis happened and it came 2021, and say, I would like to consider pregnancy. Will you allow her to tell her, no, yes, adopt, have a dog, or what you do?
Well, first, we would consider at least 6 months after the thrombosis, so we try to avoid the high risk of recurrence. Putting the pregnancy, that's a high risk for new thrombosis. So first thing, 6 months after the thrombosis, and then that's very important. Patients that have pulmonary embolism, they have a cardiac evaluation because pulmonary hypertension is very severe during pregnancy. We can have 50% of maternal death during pregnancy if they have severe pulmonary hypertension. So I would wait the 6 months, do cardiac evaluation. If she doesn't have pulmonary hypertension, she can get pregnant. If she has pulmonary hypertension, I would consider against the pregnancy. But if she's doing better after all this, probably actually she's going to be anticoagulated, but she will keep it during pregnancy, changing to heparin. But the main thing here, I think you should look for pulmonary hypertension. We cannot miss that. I do for all my patients that had pulmonary embolism or maybe multiple, more than one thrombosis, at least for a cardiac evaluation at the beginning of pregnancy. Maybe, and in the countries that you can interrupt pregnancy, you can maybe recommend against it.
Guillermo, do you have, you will allow her to fall pregnant, or we counsel her to, this is too risky for you?
No, at this point, she's 24, she's got a lot of years to get pregnant. First, you have to work out to see what's going on. And in any case, if I don't find anything and we end up adding any other treatment, I think I would wait at least for 1 year to be sure that it's not recurrence.
Okay, Katrien?
Yes, I agree. In fact, I have nothing to add. Yeah.
Okay, let me move to the fourth case. You know, this is my favorite case. Okay, it's about the non-criteria APS. You know that it's my passion for this, and because I have seen many patients with this. Let's discuss it. We have about 5-7 minutes to do this. 30-year-old white female, previous history of persistent headache, memory impairment, brain MRI, small vessel disease, prominent livedo reticularis in both legs, and she had severe preeclampsia and stillbirth at 34 weeks, okay? It sounds antiphospholipid syndrome, at least clinically, all right?
Yeah.
So we go to testing, and this patient, Katrien, if she comes to your clinic in 2005, you will not label her antiphospholipid syndrome, is that correct? With that serology.
So she is only
Katrien?
anti-beta 2 GP1 positive, if I see
Yes.
it good? Yeah.
Yes. What you label her? In 2005, I am going back in the years, back. If this patient come to your clinic in 2005, you would have labeled her antiphospholipid syndrome?
And is this persistently positive, anti-beta 2 GP1?
Yes. Yeah.
High titer.
Yes.
And you retested anticardiolipin antibodies?
Negative.
With another assay?
Yes.
Also negative?
My point is
also negative
yes,
with another assay. So it's really a single anti-beta 2 GP1?
Only, yes.
Only. Today, I should test for antidomin 1 antibodies.
No. You didn't understand my question. We're stopping the clock. I am going to 2005, 17 years ago. If this patient come to your clinic, you would have labeled her antiphospholipid syndrome, yes or no, with this serology?
Yes, it's when it is high titer and persistently positive. Strictly, it is sufficient, yes. Certainly when it is a high titer.
But it wasn't criteria. It wasn't criteria anti-beta 2 glycoprotein 1 2005. I do it because we are research center. Okay? Wasn't criteria. I did it. I know about it. I know about it because I do it. I established this test in our lab in 2000 or 1995 maybe, okay? But it wasn't criteria. It became criteria 2006.
Okay. Yeah, I understand. So before it was added to the criteria, it could be considered as a seronegative APS then?
Yes, this is my point. This is what I'm trying to lead the discussion and by years. So what we changed, we didn't change the patient. We changed the year of diagnosis, okay? Let me move on, just to illustrate my point, okay? You come to this patient and you test ACL negative, lupus anticolon negative, anti-beta 2 glycoprotein negative, and happen to be, you do research because you are hematologist, you are interested in anti-PSPT, antiphosphatidylserine prothrombin, and she is positive. Today, you will not label this patient as antiphospholipid syndrome, do you?
Yes, for me, this is certainly based on the clinical symptoms. This is an antiphospholipid syndrome. And depending on the date that you say, it is an antiphospholipid syndrome fulfilling the lab criteria or not.
Yes, this is the point. This is exactly the point.
Yeah.
This is exactly the point, and this is what I am trying to illustrate with this. And this what my friend Erkan yesterday stressed in his classification criteria. He said, guys, we are establishing classification criteria, not diagnostic criteria. We don't have diagnostic criteria for lupus. We don't have diagnostic criteria for the rheumatic diseases in general, and we don't have diagnostic criteria for APS. So you have to be open-minded. When you think antiphospholipid syndrome and the sound antiphospholipid syndrome, call it whatever you want to call it. Seronegative APS, call it whatever you want, I don't care. But treat these patients. Don't ignore them. Don't ignore them. While we are changing the criteria for classification purposes, to put them together for trials and for studies, but don't be clinician, always be clinician. Some of these patients are being undertreated. And this is the point of the seronegativity. And we prove that. We prove that, not because I am behind this. I'm not behind this because I've seen many patients with this. Small number, but because we are a referral center, we saw many of them. They come after they visit, after many, many visits, and being ignored. These patients are being ignored. You as a rheumatologist, Guillermo is expert in the field, De Jesus is expert in the field, you won't ignore them. But our colleagues in other specialties, in neurology, in cardiovascular medicine, they don't understand the concept of seronegative APS. They don't understand that. They don't understand the non-criteria manifestation of APS, serological manifestation. And this is why I keep dwelling on it, because small number of patients is being undertreated. And we proved that.
Dr. Munther, we must finish in 1 minute.
Okay, that we proved that by comparing seronegative and seropositive. There is no difference between the two. And we did a test, we did a study with Laura Bertolacini helped me in that, to blind the samples. We sent them to a laboratory in the United States, and 1/3 of the patients who we labeled at St. Thomas's Hospital as seronegative, they have seropositivity for tests that we don't use in clinical practice. The tests like phosphatidylserine prothrombin, phosphatidylethanolamine, and so on. But don't undertreat these patients. Call them whatever you don't want to call them seronegative, that's fine with me. Call them possible antiphospholipid syndrome, potential antiphospholipid syndrome, but don't ignore these patients. And I hope myself that perhaps some of these biomarkers that we have will be included in the new criteria, but I'm not sure this is the case. In the case phosphatidylserine prothrombin is quite specific for thrombosis, but here we go. We are going to wait for the criteria to come out. Thank you very much, all my colleagues who participated in this debate. Thank you for the audience, and thank you for participation. I think this kind of debate is always interesting, and I hope you enjoyed it. Thank you very much, and have an excellent day. Thank you. Bye-bye.
Thank you.